Over the last 20-30 years, ultrasound examination has been advancing significantly. It is one of the most frequently used modality for the diagnosis of many diseases, particularly abdominal diseases. In acute setting, including a trauma and acute abdomen, ultrasound examination has a significant role. First examination has been used over 10 years, not in the United States or Japan, but all over the world. And this is one of the modality everybody using now as a first life-saving examination. The training is a very key portion of this ultrasound examination. Unlike other abdominal disease, it is not teachable easily during the acute setting, like very unstable shock patient in an emergency room. Even acute situation, teaching and student or learning person may not be always available. Therefore, consistent and systematic teaching in acute setting in the emergency room, like acute trauma or acute abdomen, is not easy. By using a new phantom, as you can see over here, developed by the Kyoto Kagaku in Japan, called the first phantom, is going to be a very useful tool in the future. This has a various pathology, including the trauma and acute abdomen setting, including cardiac tamponade, hemothorax, abdominal bleeding around the liver, pancreas, and the pelvis, around the liver and the spleen and pelvis. These are the first examination. But also, this includes several pathology in acute abdomen, including acute cholecystitis, cholangitis, AAA suspecting rupture, and also left lower quadrant colonic diverticulitis. So these pathology can be included in this first phantom, and this can be used for the training of the young people, including a student, resident in the future, and particularly this can be used for the teaching, but also the evaluation of the young people if they learn actually the first examination or examination in acute setting, like in an emergency room. This is a demonstration of the abdominal examination using this first fan. This phantom was made originally for training first examination, FAST examination, but also there's some pathology inside, which I'm going to tell later, for the patient of the acute abdomen. First, I'd like to review first examination using this phantom. Adjustment of the setting is already made, and you are now seeing the liver by scanning subcostally. And the first examination is a 4-component. One is subcostal scanning or subxiphoid scanning, right intercostal scanning or subcostal scanning, right upper quadrant, and the left upper quadrant scanning or left subcostal intercostal scanning, and then pelvic scanning, suprapubic scanning. Now, first, let me show you the subxiphoid scanning, which is usually performed to the evaluation of the cardiac tamponade. You can scan the longitudinally usually first, and you see here the liver, left lobe of the liver, here's the diaphragm, and you can see the heart. In the actual patient, of course, I hope the heart is beating. Over here, you see anechoic, structure inferior to the heart, which is basically the fluid in a cardiac sac in the trauma patient. Most likely it's a cardiac tamponade and bleeding. So you can see this very quickly by first step of the cardiac first examination. Here you can see sagittal section, but in some patient, depends on patient situation, you can also do the transverse section like this, and you can see the fluid. And certain patient, particularly trauma patient, you cannot ask the patient most of the time to take a deep breath, or patient position cannot be changed. So sometimes you may need to scan anteriorly like this, seeing the pericardiac area between the rib, and you can see over here cardiac muscle, and again anechoic structure surrounding this muscle, which is the cardiac tamponade. So this is the first step, and the second step is right upper quadrant, and you can see scan intercostally or sometimes subcostally. And subcostally right now I'm showing here. Here's a kidney, and let's see, increase the size. Here's a kidney. And this is the edge of the liver over here. And this is the so-called Morrison's patch, which is most dependent portion of the right upper quadrant. And you see the anechoic structure. Again, this can be just ascites or bile or something, but in a trauma patient, this must be the bleeding. So you see here, most dependent portion, you can see the blood over here. When the bleeding accumulates more, you see the fluid surrounding the liver like this. Over here, you see the anechoic structure surrounding the liver, even going anteriorly. When the blood going to the anterior, it means large amount of the blood loss usually. So this is the right upper quadrant first examination. And then go to the next left upper quadrant. Usually subcostal scanning does not work because of the gas obscuring the structure. So you need to go very posterior and superior area. And you see now spleen here, and then kidney. Again, between the kidney and the spleen, you see this anechoic structure, which is blood in the case of the trauma patient. So you see left upper quadrant is also, you see the blood loss over here. And then at the end, the fourth portion is a pelvic scanning, which is bleeding most often associated with the pelvic fracture. You see first bladder, which is anechoic structure over here, and in the male, in this phantom, let's see, make it a little bit smaller. You see the rectum over here. In women, you see the uterus and rectum, but in the men, you see rectum over here. And then in the very deep pelvic area, you see the anechoic structure. Again, this is a blood in the case of the trauma patient. You can scan the sagittal section by rotating a transducer. Again, here's a urinary bladder. This is the rectum, and this is the blood in the pelvis. And you see some bowel over here. So first examination usually originally subxiphoid, right and left upper quadrant, and the pelvis. But now you can do also extended first examination, which is a variation of the hemothorax. Basically, by extending the transducer and the right upper intercostal scanning more superiorly, you can see the hemothorax over here. Let me freeze the image one time. Over here, you can see the liver and the fluid outside of the liver, and this is the diaphragm, and this is the lung, and this is the pleural space. You can see the fluid over here, which is in the case of the trauma, blood, and you can see this fluid surrounding the this is the lung. So surrounding this lung, you see some fluid going all the way down in the posterior recess of the pleural space over here. The same thing you can see on the left upper quadrant. This is the spleen again, but moving the transducer more superiorly. Sorry, over here, here's the spleen again, and you see the diaphragm. And here's the lung, and here's the pleural space. You see the anechoic structure, which is basically hemothorax. So in the first examination, you can extend the examination to the thorax, which you can evaluate by which you can evaluate the intrathoracic structure. Pneumothorax can be also evaluated by the ultrasound, but in this particular phantom, it is not shown the pneumothorax. So first examination again. Subxiphoid, right upper quadrant, and extend to the right chest, left upper quadrant, extend to the left chest, and then finally pelvic examination, which should be done in 1 or 2 minutes in a trauma patient, particularly patient is in a traumatic shock status. In this first fan, there are several pathology which is made for the acute abdomen setting. You can see already blood around the liver, but ignoring that, you pay attention to the gallbladder here. If the patient comes to the emergency room with acute abdominal pain, particularly right upper quadrant of abdomen, you do the CT scan, but also ultrasound is also oftentimes helpful. Here you are seeing the gallbladder, which I can magnify and you see much better. And this gallbladder is obviously abnormal. You see here the stone, and this is a sludge with a layering. There's another stone over here. And here you see the wall of the gallbladder is very thickened. So this suggests the acute cholecystitis. In this particular phantom, you don't see pericystic fluid collection, but you can see this wall thickening, probably over here, maybe. Let's see. You can measure the thickness of the gallbladder wall by putting a cursor. Usually, this is measured at 6 millimeter, but usually larger than 3 millimeter is abnormal. So there's a few criteria of the acute cholecystitis, like a distended gallbladder, sludge or stone inside, wall thickening, pericholecystic fluid collection, which can be evaluated by the ultrasound. And also, ultrasound Murphy sign can be evaluated by putting a transducer on the top of the gallbladder and ask the patient to take a deep breath, which causes the pain, which is positive Murphy sign. And this particular phantom, you also see a gallbladder, but also the bile duct, and you can see over here, slightly dilated bile duct over here, and also the stone in the bile duct. You can see 3 stones in the bile duct, which indicate this patient or phantom might have the acute cholangitis in addition to the acute cholecystitis. So if the patient comes fever, pain, jaundice, it's obviously indicating the possibility of the bile duct stone, which can be confirmed by the abdominal examination, as you can see over here. The second pathology is that if patient comes to the almost shock status with the abdominal and back pain, you can see the abdomen like this, and particularly if the patient is very unstable condition, cannot be sent to the patient to the CT scan. Ultrasound is very variable study, and as you can see over here, you see dilated aorta. This is the aorta proximally and distally. You can see the balloon dilatation of the aorta, which indicate obviously aortic aneurysm, AAA. And this is a longitudinal section, and this is a transverse section, you can see. AAA can be followed by the ultrasound in a stable condition, of course, but by acute setting, you can also do the ultrasound to include or to diagnose or exclude the aortic aneurysm. And of course, the size can be measured by putting a transducer cursor like this. This is a cross section, up and down and right and left measurement. And you see now like a 4 by 4.7 centimeter aneurysm over here. And this particular aneurysm, you can also see the intra-aneurysmal thrombus formation over here. This is a more anechoic structure, but near the wall you can see the thrombus. Of course, this phantom doesn't show any retroperitoneal bleeding, but at least you can see aneurysm, which is very helpful in a patient with acute abdomen with a shock status. The last pathology is if the patient comes to the emergency room right or left lower quadrant. If it's right, you suspect the appendicitis, but if it's a left lower quadrant, it can be a colonic diverticulitis. And of course, CT scan is one of the modality you can do, but also in emergency room, you can use the ultrasound. And if you see some inflamed structure, associated with the colon, which is here in the left upper quadrant, left lower quadrant, which is descending to the sigmoid colon area. And you see here a little bit inflammation and also some anechoic structure indicating some abscess formation. And particularly if this area, the ultrasonically by pushing the transducer, if it's painful, it must be the source of the patient's symptoms, and in this case, diverticulitis. And if it's already perforated and very large abscesses formed, ultrasound can also be used to drain these abscesses. This is an abscess over here, small, multiple tiny abscesses, but not large one, but you can see over here typical appearance of the diverticulitis. So in this particular first span, there are several other abnormal structure, right upper quadrant, acute cholecystitis, bile duct stone or acute cholangitis, and in the mid-abdomen, aortic aneurysm, and the left lower quadrant, colonic diverticulitis, which is very helpful for the emergency setting performed by the emergency physician or surgeon in the emergency room.